Dr. Jaimir sir, you can start the comments of my
Thank you
talk
very
and
much, Dr. Natarajan, for a brilliant presentation as usual. And we are indeed proud of you for having initiated this new concept in genetics and organizing the first Global Eye Genetics Consortium with an international faculty. I only wish more people would take advantage of these sessions, and the interest in genetics can be increased in the near future. The first session we are having is the ophthalmic genetics for practicing ophthalmologists, case-based discussions and FAQs. This is under the aegis of the Maharashtra Ophthalmological Society and the Bombay Ophthalmologists Association. Our co-chairman is Dr. Preetham Saman and Dr. Santosh Pide and Dr. Anand Subramaniam. Our moderator is Dr. Siddharth Kesarwani and our convener is Dr. Sonal Lakrawala Jadhav. Yes, the panelists and the speakers are, which one? The last. For the panel discussion, we have Padma Shri Professor Dr. Natarajan, Dr. Somil Sheth, Dr. Nipa Thakkar, Dr. Anaga Heru, Dr. Mamta Muranjan, and Dr. Nishikant Borse. I hope they're all here.
Excuse me, sir, just for 10 minutes.
Yes.
I request Dr. Karovi to give moment to Dr. Padma Shri, Dr. S. Natarajan, sir. Sir, be on them. Thank you so much, sir, and thank you so much, ma'am. We can proceed with the session. Thank you.
Yeah. Our first speaker for this session is Dr. Parveen Sen, and the topic is phenotype and genotype correlation in RP. Please introduce the faculty.
Good afternoon. Dr. Parveen Sen is a senior vitreoretinal surgeon at Agarwal Eye Hospital, Chandigarh. Former senior consultant, Shankar Netralaya, Chennai. Over 100 publications, 7 chapters, and co-authored 3 textbooks, several invited talks. She's a reviewer for national and international journals, and her areas of special interest include ROP, retinal imaging, pediatric retinal surgery, electrodiagnostics, and hereditary disorders of the retina. Is Dr. Parveen Sen here? Online. Okay. Yeah, has she joined?
Yeah, you can see my slides, Sonam. Hello. Am I audible? Hello. Are you able to hear me?
Please go
Okay.
ahead. Start.
Okay. I, at the outset, thank Dr. Natarajan for giving me this opportunity and congratulate him for holding the first GEGC meeting in India. So my topic for today is phenotype and genotype correlations in retinitis pigmentosa, and I will talk a little about a few other diseases in the retina. And as we know that more than 270 disease-causing genes are known to be associated with inherited retinal degenerations, and there is extreme genetic heterogeneity of the disease as well. So molecular diagnosis is technically very challenging because it involves a lot of commitment of substantial time and resources. Not many gene-identified patients are there seen in India. We don't have the registry of a lot of identified genotypes and phenotype correlations in India. And there was a talk early in the morning about the need for this kind of a registry. And I'm glad that we are setting forward taking a lot of steps to set this in India itself. I'll share some work which has been done in the last few years that I have been in Shankar Nethralaya. So we know that inherited retinal disorders can be single gene disorders or multiple gene disorders. The single gene disorders like X-linked retinoschisis, generally it is very easy to establish a phenotype-genotype correlation because you see a typical phenotype of foveal schisis, along with it a typical ERG of negative waveform, and you know that this is X-linked retinoschisis which is caused by RS1 gene defect. You may or may not really want to ask the patient to undergo a genetic evaluation. Similarly, this is another typical phenotype with you have annular reflex ring of pigmentation, which is present here, or you could have teprido-like lesions, which are seen very clearly here. Again, the annular pattern of degeneration, and you have these yellowish subretinal spots in the periphery. And if you see the OCT has this presence of foveal schisis and typical ERG waveform of these broad, shallow waveforms, and you know it is enhanced S-cone disease that you are looking at. Again, another other inherited retinal degenerations like Leber congenital amaurosis or RP. These are known to cause by a lot of genetic mutations. And in these cases, a simple fundus examination and a typical examination on multimodal imaging may not be sufficient, and you need to see more and more of these cases to establish a phenotype-genotype correlation. So LCA, we know, is a group of severe inherited retinal dystrophies, and it's characterized functionally by severe visual impairment, sensory nystagmus, and unrecordable ERGs within the first year of life. And it can be caused by more than 20 genes, which can have a similar functional spectrum of very poor vision and unrecordable ERGs. So GUCY2D, this is the most common gene which can give rise to LCA, and you can see the range is from a near normal looking fundus with this tapetal reflex, but on the other extreme, LCA can also be caused by a mutation in the RDH12 gene, and this can give you a typical colobomatosis macula and a very distorted looking fundus picture with optic disc pallor and arterial attenuation. Another gene which can cause LCA is the Crumb's homolog 1 gene, the CRP1, and this is associated with a typical sign which is the para-arterial sparing of the retinal pigment epithelium, and this is typical of CRP1 mutation. Also, you can see the kind of pigment that you see in CRP1 homolog gene mutation is numerar, coin-shaped, and not the typical bone spicule pigmentation. And attention to these details can give you some inkling as to what is the underlying gene which can cause LCA in this patient. And specifically in this era of gene therapy, it is very important to not only know that the child has LCA, but also to know which gene is causing LCA so that you can guide the patients accordingly. So just to highlight how different two presentations of LCA can be, both are Leber's congenital amaurosis, but on one side, this large columbomatous area in the macula, and on the other, a near normal looking fundus. This one is caused by RDH12 and this one by TULIP1. So same thing can apply to retinitis pigmentosa, only thing is the spectrum is even more varied. Here we have more than 100 genes which can cause RP, and this is all non-syndromic RP that we are talking about. Symptoms will remain the same. Patient will come to you with night blindness, progressive vision, field constriction, and finally loss of central vision. In general, we know that autosomal dominant diseases are less severe as compared to autosomal recessive, and X-linked RP can have most severe bad prognosis and early onset. These are some genes which can cause autosomal dominant or recessive or X-linked RP. So we did have a chance of evaluating almost more than 152 patients with RP phenotype, and they underwent genetic testing, and we found a specific mutation in 72 patients, and in 23 had a variants of unknown origin. We found that circle mutation was the one which was most common in our population of patients with RP. And you can see it is quite atypical. It's not something what we typically think of RP. We think it is usually macula sparing, but circle mutation usually presents with early macula involvement, and this typical coin-shaped lesions in the periphery of CRA or atrophy, and paucipigmentary, very few pigments are there. And this is important to know this kind of phenotype, because otherwise we generally keep thinking that this is probably gyrate or choroideremia. But RP due to circle mutation can also present like this, typical extinguished responses of retinitis pigmentosa. PROM gene is another one which can cause these kind of peripheral CRA patches kind of appearance, but you can, if you careful examination can tell you that here also early macular involvement is there, but there is a lot more pigment than what you saw in circle mutation causing RP patients. So here the difference is a lot of pigmentation is also present. Another picture from literature also shows something very similar to the previous case that I showed you. There is extensive dispersal of pigment and early macular involvement, and this kind of CRA patches, which are very diagnostic. So this gives you a severe phenotype, early onset, early macular involvement, and this again is PROM1 gene for you. So another one, even RP65 can have these kind of peripheral CRA patches. So this can not necessarily be only gyrate or choroideremia. Vis-a-vis RDH12, as we saw in LCA patients, here also it gives rise to a large macular scar. And if you see the autofluorescence as a typical sign of preserved RP around the optic disc. So this is generally due to underlying RDH12 mutation. And again, macular coloboma is very commonly seen, as we saw in patients with Leber's congenital amaurosis as well. And even if you don't have macular colobomas, you will have something like an overt pigmentary retinopathy if it is seen in posterior pole. Generally, the underlying mutation is RDH12. ABCA4 is very typical presentation, again, early macular involvement, and this typical boundary between healthy and unhealthy retina in the mid-periphery will give you this evidence that ABCA4 causing retinitis pigmentosa. This is what we earlier used to sometimes call central RP, but now we know that it is nothing but ABCA4 causing decreased rods and cones in a generalized fashion, and this is ABCA4 causing retinitis pigmentosa. EYS gene, or the eyes shut homolog gene, usually has a later onset, late macular involvement, and the pigments are also very few. Sometimes it can give rise to this annular ring around of pigments around the arcades. PRPF31, this is usually a macula sparing one, but CME, most of the CME, if you see with RP, are nothing but a manifestation of this underlying gene. The only problem with phenotype-genotype correlations is that you must factor in the age of the patient. Here you can see this younger age, you will have macula which is spared, but as you see the older siblings in the same family, same mutation, you can see that macula also gets involved. So just a single presentation may not be able to give you the phenotypic and genotypic correlation. As the age advances, if macula is not involved initially, it may get involved later. Another one, again, same gene, but phenotypic heterogeneity is also present. Here you can see macular involvement early on. Here you can see macula spared, but the presence of these yellowish kind of spots. But underlying genetic defect is both, in both cases, RP65. This is another example that I can give you, that this is USH2A, which we know causes paucipigmentary kind of RP, retinitis pigmentosa with the arterial attenuation. So we were thinking that this patient did come with arterial sparing of the RPE. And this is not typical of USH2A, but it is more. When we looked at our genetic report, in addition to USH2A, the patient also had a VUS, which was at the Day-1 gene. So it had found its published articles are there from the Western population, but mutation spectrum in each country can be different, and we need to analyze our cases to see how these genes are behaving in our population. So two approaches to identify the causative gene, phenotype-based and gene-based. Until we can offer gene-based approach to all our patients, we need to do good phenotype of these patients to have a better understanding of the disease and help our patients in a better fashion, because this will help in disease prognosis and development of future gene therapies. Thank you. This is my team at Shankar Nethralaya, which helped me connect all the data. Thank you.
Thank you, Dr. Parveen. That was extremely informative. And I'm sure all of us know it's quite a difficult spectrum to treat when it comes to all our patients. I'm going to give the mic to Dr. Siddharth to introduce our next speaker.
So our next speaker is Dr. Preeti Kamdar. Dr. Preeti Kamdar is a consultant ophthalmologist in Matunga, Mumbai. She is currently practicing at Dr. Kamdar Eye Clinic and Jashem Eye Institute, Mumbai. Dr. Preeti Kamdar is a qualified ophthalmologist, and her area of expertise includes cataract surgery, corneal treatment, eye checkup, and laser surgery. She will be talking about glaucoma genetics and the clinician. Yeah. You can start, Dr. Preeti.
Good evening, everyone. I thank Dr. Karobi and Dr. Natarajan for the opportunity. The idea that glaucoma could be genetically transmitted disease came from the observation that patients who suffer from glaucoma have relatives who also suffer from glaucoma. So over the years, a few genes have been studied, and through this lecture, I will try to list the genes which have been studied so far, what has been discovered so far, and how can we incorporate these genetic studies into our clinical practice. So glaucoma is not only clinically distinct in the sense we have POAG, which behaves very different from PACG as compared to congenital glaucoma. So it's not only different clinically, but it is also different genetically. So these genes which you see just now, these are the genes which have been discovered and which are found to be associated with glaucoma. They are not the same across ethnicity. So an Asian will have a different set of genes. A European person will have a different set of genes. Very few genes are multi-ethnic. Now all these genes, they are just risk factors. By itself, they are not enough to cause disease. Okay, so this is for POAG. Similarly, we have another alphabet soup for PACG. Again, the genes which have been discovered for PACG are not found in patients who have primary open angle glaucoma, of which the most commonly known or the most well-known gene is this MMP9, which codes for the metalloproteinases and also is responsible for elevated intraocular pressure and a small eyeball in PACG. So this is what is found in Asians in PACG. And now this is for pseudoexfoliation glaucoma. LOXL1 is the most commonly found gene in pseudoexfoliation, and it is found across ethnicity. So it's found in Asians and Europeans and Africans. But however, it's still not sure whether pseudoexfoliation glaucoma is a genetic disease or it is merely an environmental disease which occurs if you have a particular gene. So the current consensus is that yes, LOXL1 gene may be necessary, but by itself, and the other genes by itself, they do not cause pseudoexfoliation. It requires environmental factors to actually go ahead and cause pseudoexfoliation. So that's the current consensus. So now, why do we not do genetic tests for all primary open angle glaucomas? We have genes which have been discovered. So now we have two types of genes that increase the risk, and that is the alphabet soup which you just saw. These genes, as I said, each one, when it works in conjunction with the others, it increases the risk. So multiple genes have to come together and then they increase the risk. But as I said, they do not directly cause glaucoma. Moreover, because there are so many genes, they do not form, it's a very complex inheritance pattern. There is no clear-cut inheritance pattern. And that's why testing these genes is of no use. But there are 3 genes which have been discovered which directly cause primary open angle glaucoma. Myocillin, which was the first gene to be discovered in 1997, and people said that, oh, the gene for glaucoma has been found. It was earlier called the tiger gene. Then the optineurin and TBK1. So now they do have a simple inheritance pattern and mutations in a single gene, and mutations in these genes are highly predictive of disease. However, what is the catch? The catch is that they occur in less than 5% of primary open angle glaucoma patients. So it's not feasible. It doesn't make sense because their prevalence is so low. So again, it is not recommended that you check for these genes in primary open angle glaucoma. So now, why do we not check for primary angle closure glaucoma? You'll realize that this beautiful diagram, it tells you that yes, genetics, the genetic makeup and all these genes, they constitute the anatomic susceptibility of a person for angle closure glaucoma. But however, you will also realize that there's a very, very heavy influence of environmental factors in converting this anatomic predisposition to actual disease. And that depends on something so variable, like the mood of a person. If he's sad, the pupil dilates and you can get into an attack. Age, yes, it is one factor. Then living habits of a person, the weather, if you're in a country where the sunlight, or for example, where there is a prolonged winter, sunlight is low, pupil dilates, you'll get an attack. So these environmental factors, so the person may have a genetic makeup, but if suppose the person gets operated for cataract early, he's never going to get the disease. And that's why you know that testing for primary angle closure glaucoma, the gene testing is quite useless. So now when is testing warranted? Only if it will impact treatment or surveillance in any ophthalmic disease. So in glaucoma, it is juvenile onset open angle glaucoma and congenital glaucoma, especially congenital glaucoma. And why is that? Because we have 6 genes which are found. Myocillin is found primarily in juvenile open angle glaucoma, and these other 6 genes have been found in congenital glaucoma. They account for about 20% of these glaucomas, and they have a simple Mendelian inheritance pattern which can be autosomal dominant or autosomal recessive. And that's why we can, if every child with congenital glaucoma should be checked for these genes. If found positive, then the parents should be checked. And then we can counsel them on the risk of future children having this disease. So this is in juvenile open angle glaucoma and congenital glaucoma are the conditions where we recommend that you should do genetic testing. Now, most of us, or earlier there was a focus on trying to predict, using genes to predict glaucoma. But now the focus is also on one more usage of gene testing is that patients with certain genes may respond better to certain medication, or the reverse, that patients with certain genes may not respond to any medication. So in that person, you may not even give a trial or a very short trial of medications and plan for surgery earlier. And if you have a condition where certain genes may respond better to certain medications, so instead of treating everyone with the same drug, we will have personalized treatment. That means we will have drugs that fit the patient. One such treatment is on the horizon, that the mice which were bred to develop myocillin mutation glaucoma, they responded, the intraocular pressure was reduced very well with a drug which included topical phenylbutyrate. So now, of course, it will require clinical studies on patients, whether those who have positive for myocilin, whether they will respond to this drug. So gene-based treatment is definitely the future for genetic testing. So the take-home messages I want to give is that multiple genes are found in POAG and PACG, but they are only risk factors. It is not recommended that you treat that you look for every patient for these genes. 3 genes in POAG are causative, but the prevalence is so low that again it doesn't make sense to check them. So 6 genes are identified in congenital glaucoma. So all congenital glaucoma should be checked for them. For adult glaucomas like POAG, PACG, what we are doing currently, that is screening patients of relatives, screening relatives of patients is what is recommended even now, and testing in future might help in personalizing treatment, glaucoma treatment. So thank you for a very patient listening, and it was nice connecting to all of you virtually. And once again, I thank Dr. Karobi and I thank Dr. Natarajan for this opportunity. Thank you so much. Bye-bye.
Thank you, Preeti. Thank you. Should we go to the next speaker or any question? Next speaker. The next speaker. Sure, sir.
I think I'm Dr. Sundaresan. We worked on extensively on genetics of glaucoma, both POAG, PACG. We only identified some of the genes for that, like that. So I think Preeti excellently, narrated as a clinician. I think is beautifully mentioned. I think I want to add only one thing. Concern with the gene screening, whatever she told is correct. If the patient is JOAG and then congenital glaucoma, definitely we can go for gene screening. And then the 3 categories is very, very important. One is, please check the family history. Family history, one is family history. The intraocular pressure should be very, very high. And then the JOAG, the age onset, less than 35. If it is less than 35, intraocular pressure is high. And then the third one is family history. If it is there, definitely we can recommend for gene testing. Thank you.
Thank you. Thank you. And I will take pleasure to introduce our next speaker, the dynamic Dr. Karobi Lahiri Coutinho. A big round of applause to what she's doing, passionate about her work. A consultant vitreous retinal surgeon and a pediatric ophthalmologist, Bombay Hospital. I'm going to start with her hobbies, that is dancing and gardening. And then I'm going to go to her academics. Presented several lectures, talks, guest lectures, orations.
Skip it.
No, I'm not going to skip it because people really need to know about you. You've written 6 books, chapters, and 12 publications. She's the Best Fellow Award from Shankara Netralaya. She's has a Surgical Excellence Award given to her. She's rated as a top doc in Mumbai twice. She's been a past president of Bombay Ophthalmic Association, a national ambassador for ROP. She's received the B.T. Muscati Award, the Ishwar Chandra Award, the Women Ophthalmology Society Leadership Award, the Women Ophthalmology Society Role Model Award, and a Shanti Niketan Award. Welcome, ma'am.
Thank you. Even I got bored of hearing my own awards. Good afternoon, everybody. My talk is on what is called is it Roper? Now, this is a terminology which is not too many people are familiar with, but to familiarize you, it is a combination of ROP combined with FEVR. There are variants which do occur, and this is a new terminology called as Roper. Now, I will present 3 cases. The first case is a 12-year-old girl. She came to us first when she was 8 years old. She is the daughter of a gynecologist, but sadly enough, she was first seen for her ROP at 6 months of age. by which frame of time she had developed there was a fold across the macula in the right eye, and in the left eye, she had a regressed ROP. She had been to prime centers in the south, and they told her that she is quiescent in one eye and nothing needs to be done. And the right eye, where she had the fold, they said that nothing needs to be done for that, just leave it alone with whatever little vision she had. So she continued like this. She came to us at 8 years of age, and at that time, from that time onwards, we have been refracting her, keeping a watch on her, and she's very, very sincere about her follow-ups. She comes every 6 months and gets herself checked out. She is now 24 years old. The problem that we found in her was when she came to the age of 12. She also had history of several fractures of the hand and leg. She's got high intellect, and she's got a lot of soft dysmorphisms like prognathism, low set ears, lowered palpable apertures, etc. But this girl, she has a falciform fold at the right macula, and in the left eye, she has got a kind of scar in the superotemporal region just off the arcade, and she could be labeled as a stage 4B zone 2 with regressed ROP changes where there were no blood vessels going to the periphery, and she maintained like this till 12 years. And at the 12th year, when I first saw her, she was looking a little different. That is, we found that there were some buds, proliferative buds, which were there at the zone between the avascular and the vascular zone. And these were ominous because the left eye was the good eye for her, the eye in which she was kind of doing all her work with. So let's see the vision. The vision in the right eye with the fold was just finger counting 2 feet. And in the left eye, her best corrected visual acuity was 618 with glasses. And she had the startings of a cuneiform cataract at that point of time. And she had high myopia, she had nystagmus, and an esotropia in the right eye. So I consulted the parent and I told her that we need to do a fluorescein angiography for her, and we'll have to subject her to laser because it is of prime importance. This is how the cataract has progressed over a period of time, right from 12 till now. We are not touching the cataract because she's still maintaining the same kind of vision with changes of glasses as the cataract is maturing. And that's the only good eye. So we are not going very strong on doing any kind of surgery till she feels incapacitated. Now, this was the FFA findings. If you see, there are these small buds which are leaking at this point. These are small kind of buds. There is a little vessel pruning over here, and this whole area is avascular beyond that. So then we went ahead and did a laser treatment, and the laser treatment was done to all the avascular areas 360 degrees, and she settled quite well following that. Now, what was interesting is that she had a family history of FEVR in a cousin whom they had brought to see me, and that patient had gone to LV Prasad, and she was from Hyderabad, so they had detected her as a case of FEVR. So this was just for our information. So we sent this girl for gene sequencing, and she went to Shruti for the gene sequencing, and they did a whole exome sequencing, and they found it was negative because we were wondering whether this is an FEVR component, which we were mistaking as an ROP. Because the child was premature. But what was interesting that it was a late onset at 12 years, and we've not really seen such late things in ROP cases. So let's go over to the next case. The next case also was a late referral to us. The child came to us at 4 years of age, where you see his photograph there. He was actually seen late initially also because the referral was late to whichever ophthalmologist he had seen. That was at 5 months of age. And by which frame of time he had landed up with a stage 5 ROP in the right eye. And in the left eye, the child had received some amount of laser, but it was that fomentation kind of laser where you found it in certain patches, and there were a lot of patches which were empty, and there was an avascular area occurring beyond that. Now, the thing is that this child, when he was 8 years old, he developed findings like this, where again, these little sprouts were coming up at the margin of the vascular with the avascular retina, not only on the nasal side, but also on the temporal side. As seen on the fluorescein angiography here, you see an active leakage over here, and there are leaking points over here. So again, this child needed extensive laser, and this was the appearance after the laser treatment. So sessions of laser were given. Okay. Now, case 3. This is another scenario where the child is not a preterm, the child is a full term. He had an uneventful perinatal period, low vision seen at 6 or 7 months by the parents, and the child was taken, and the RD was detected in this child in the right eye at 22 months. Now, again, the child had gone to 2 major centers, and at one center, they had examined the other eye under anesthesia, and they had done some amount of laser treatment to a lattice degeneration, which was there in the superior temporal quadrant in the left eye. The right eye, they said that it's stage 5. It looked like a stage 5 ROP. And they said, no, that this could be an FEVR because there was no history of prematurity. Again, she was sent for genetic analysis over there in South, and they did not really find anything conclusive. And then I'll tell you what happened after that. And this child had a short stature, had microcephaly, facial dysmorphism, and had high myopia. And so a genetic workup was advised because the thought was it was an FEVR. So now by the time the patient was seen in those centers, it was on in March 29, 2022. And the right eye, as you see in this, has got a complete detachment over here. And it looks like a stage 5 closed funnel detachment. Whereas the other eye, which is high myopic, you can see this readings over here, has got perfectly settled retina. There's no problem over there, and had probably the lattice degeneration, which was treated at this center. Now, when the child came to me on 28/5, that was the first time I've seen the patient, the right eye continued like that, but in the left eye, when I checked inside the eye, because the parents said since 2 days the child was fumbling. So I checked out and I found there was a retinal detachment, but the child was very cranky and, he was not allowing a proper examination. So, and I wanted to know the extents, whether the macula was detached or attached. So I sent him for an ultrasound to our very own Deepak Bhatt, and he did the thing and he said that the complete retina was detached in that eye. So we took the child up for surgery. A buckle was done in the left eye, and in the right eye, 2 months down after finishing the left eye, when the child was doing quite well, we operated the right eye also for the scrolled up detachment that the child had in that eye. And this is the post-operative results. Now, the post-operative results, we had to sacrifice the lens in the right eye. So he's got a +16 diopters of hypermetropic correction in the right eye and -15 in the other eye. Again, this child had seen Shruti, and she ran some tests for him. And she also confirmed the no block syndrome, which was earlier also cited by the people in Chennai. So the thing is that there was an uncertain mutation of COL18AI gene, but only one gene copy was available, which is what they call as heterozygous. This is Greek and Latin to me, but she tried to explain to me in a very good way. And she said that you have to have 2 copies to have a distinctive diagnosis. So I take it. It's that way. So this is an autosomal recessive type of inheritance which the child had. And then going through various studies, we found that study variants in FZD4 or LRP5 or NDP genes account for 3 to 12% of eyes with ROP. What was interesting is that this is late presentation, which doesn't occur in ROP. The clinical history of prematurity, whether it is there or there is a family history, will help you detect. FFA, if you can do the findings of the pruning, the hyperfluorescence and the avascular zones, the genetic analysis and the bone densitometry, which is very useful. Now, for discussions, as we saw that these are children which can be termed as Roper because they belong to both these categories and we cannot differentiate one from the other, except if they have a positive history suggesting the same. And the ROP, as I said, is more earlier and FEVR occurs later. But as we've seen a reversal, there was only one child who had a proper variant which was positive. The other 2 were query. And here what happens is that the mutation of genes with less functional impact led to advanced ROP. That is how studies have shown. Whereas mutations with greater phenotypic consequence leads to FEVR. These were their conclusions. So these children need to be monitored very closely for disease progression in their life, especially if they have regressed ROPs, and they require serial angiography from time to time if you feel that there is something which is risky. Now, in case 1, there was no FEVR gene variant detected. In case 2, there was an LRP5 variant detected. So that's why it was a clear-cut Roper, because the child was premature also. And case 3 had a no-block syndrome with that COL18AI variant. And I won't get sleep after all these high-sounding terms today. Now, the bone densitometry scans did show a low bone density in the first 2 cases. I have not done it for the 3rd patient. And the first patient is hypothyroid on thyronome, which were additional features adding to the probability of a Roper. So this was just a summary of both the cases, 2 preterms, 1 full term, and detected in 1, not detected. So the tenets are: send the complete phenotype. Every genetic test need not be taken at face value. Sending tests without complete phenotyping can be sometimes hazardous, because a maze of uncertain results crop up and they make the journey more expensive, more tedious, and more difficult for the patient's family. So the vital question is, do we laser every patient of regressed ROP, lest they do not maintain a strict follow-up, long-term follow-up? And is it a really ROP variant, or is it a Roper? That is the vital question. So what we have to do is that if the patients follow up well, you maintain a close follow-up. And if you find even a hint of something suspicious, treat it immediately. Or sometimes if there is no follow-up, then it is better to laser. So you throw away the dangling sword of uncertainty in case of probable faulty follow-ups. Thank you so much for your kind attention.
I liked your term, fomentation kind of laser. So if my fellow doesn't do good laser, I'm going to call it fomentation.
Fermentation, yes.
Thank you, Dr. Karupi.
Thank you.
Yeah, I would like
Thank
to
you, ma'am. Just a second, sir.
for the momentum, ma'am. Please.
I will request Chairman Dr. Preetam Samant to give momentum to Dr. Karupi. Thank you, sir. Thank you, ma'am.
While we are at the topic, can I have your attention, Dr. Shruti and Dr. Mamta? One small question to you. Is there any gene associated with ROP as such? Because we see children with all risk factors not having ROP, and children with who are doing very well get ROP. So is there any genetic predisposition for getting ROP? Is there a gene for it?
So at this point, I'm not aware of any specific gene or even polymorphisms associated with ROP. I don't know whether Shruti is aware, but the suspicion would be it may not just be a gene and effect. It could be a predisposing genetic makeup with added environmental influences. So a gene environment, effect together. Shruti, if you would like to add.
I agree. So similar to, yeah, sure, sir. So quite similar to this is the spectrum of cerebral palsy, where not everyone who gets asphyxia runs into CP. So I think it's a matter of time till we discover more monogenes related 1:1. But I agree with ma'am, we were discussing the same thing, that maybe a pure ROP is as of now polygenic, affected by epigenetic mechanisms, and maybe we need more studies, but as of now, none that I'm aware of either.
And just a random thought, you're like in FEVR, the phenotypic tissue is the retinal vasculature. and ROP is a disease of the retinal vasculature. So maybe that's why the overlap is giving rise to Roper. So I'm sure probably in the future, people will describe such more overlaps, where you have genetic diseases associated with retinal vasculature and you have ROP. I'm sure such kind of variations will come up.
See, there are some 5 or 6 which are responsible for the FEVR, but they have cited these LRP5, then NDP genes, and which was another one? Yeah, so those are the genes which are responsible for ROP with FEVR-like features.
I think there is a study from LV Prasad, Indrajit, she did in ROP, she compared both the proteomics, proteomics data and genomic data together. I think they did some Jiva study and proteomics, but again, there is no conclusive gene is there. Like myopia, people are jumping on myopia. I think so many genes are there, but we can't able to correlate directly to myopia or FEVR or ROP. We have a long way to go. Definitely, if we stringent the clinical criteria, but here the combination of FEVR, ROP together, something like that, no. Stringent the clinical criteria and then do the perfect genotyping, we can come up with the right candidate gene for the particular disease. Thank you.
The same thing, agreeing that probably gene environment interactions are more common in these kind of disorders. Also, if we see that genes which are associated with this Roper, that NDP gene is actually also causing coats, it has been associated with Norris disease, all are vasculature affecting diseases. And swinging in such a small percentage of these, it could be just a coincidence as of now. We don't have that much evidence. But yes, until unless, like, this is what is deep phenotyping is, right? Until we categorize and deep phenotype is, we won't have these questions in mind to, further find out the answers. So thank you, ma'am. Very, very interesting case.
Yeah, thank you very much. Enlightening session there. For another enlightening session, I am inviting Dr. Paritosh Kamdar for his talk on gene testing in private VR practice. Dr. Paritosh is a well-known vitreoretinal surgeon from Session Eye Institute in Mumbai. He has a very long list of awards, and he has got the International Ophthalmologist Education Award from AAO in the year 2008. Thank you, sir, and please start your talk.
Good afternoon, everyone. Respected Dr. Jahangir, respected teachers, seniors, and dear friends. I'm extremely grateful to Dr. Natarajan and to Dr. Karobi for inviting me and prodding me to talk something on genetics. As a result, I think my knowledge levels increased tremendously over the last few days of preparing this. So unlike so many past masters who have already delivered their talks and many who are going to deliver it a little later. So unlike all of them, my talk is going to be a very, very basic one in a small vitreoretinal practice in Matunga. What is it that we do and how do we try to apply this knowledge? So I have been, the common reasons why I get gene testing done or advise it. Not all the patients get it done, but many do. So it's for inherited retinal and choroidal disorders, including retinitis pigmentosa, macular and choroidal dystrophies, age-related macular degeneration, suspected primary vitreoretinal lymphoma, recurrent anterior uveitis, uveitis prior to starting immunosuppressive treatment, some cases of hyperhomocystinemia, and in Wolfram syndrome. So far as primary vitreoretinal lymphoma is concerned, I'm not going to elaborate too much because we have a talk about the MYD mutation later on by my teacher, Dr. Biswas. But it's a very useful test for quick diagnosis. Recurrent anterior uveitis, as all of us are aware, somebody with back pain, just get an HLA-B27 done. If you know that it's positive, then you can treat that patient and tell him what precautions to be taken to prevent recurrent attacks, as well as to for quick treatment of the attack the moment he realizes he's gone into one. Hyperhomocystinemia. Earlier, I used to get the MTFHR mutations done until a senior physician told me that it's no point, it's not cost effective. Just treat it with folate, B12 and pyridoxine. The cost of that treatment through his lifetime may be less than the cost of the mutation testing. So this is a case 31-year-old patient who's having gradual loss of vision, diagnosed as Stargardt's. We found all these abnormalities. And this was a phenotype, very familiar phenotype that we all are aware of. But he mentioned that it was a very slow decrease in vision that he was experiencing, and that he was able to, he was quite fully functional, using certain low vision aids or expanding the font size and contrast on the computer. I advised him to get his parents tested, and he has an only child. So, he was very anxious whether she would inherit this or not. So they tested. Luckily, the child doesn't have abnormalities. The father was detected to have the gene. It's heterozygous, and luckily, since we have that background and it's the same gene abnormality, same mutation on the same exon which was detected, and since the father is still seeing at an old age, it's in a way a good prognostication for this patient. This young man was actually advised to undergo keratorefractive surgery. He came to me for a second opinion, and this is what I found. Again, Stargardt's history of consanguinity was there. He was advised to undergo gene testing, and again, we find the ABCA4 mutation, which is present on the exon 21 this time. It's different from the previous patient, and it's homozygous. Now, I advise his parents also to undergo testing, which they have not yet agreed to. But since it's homozygous, it's obvious that he's inherited, one abnormal gene from his parents. This was another young girl who, again, Stargardt's, again a different location of the abnormal ABCA4 mutation. But it was, although it was homozygous, it was an autosomal recessive. That explains that why she is manifested. But the classification was uncertain significance. Now, this is something I will leave it to the geneticists to really discuss and debate about. But here the issue was she's been married just a couple of years ago, and they are planning to have a baby. This is a phenotype. So she was concerned whether she's likely to transmit the genes to the baby or not. So genetic counseling was done. Here there is one more confounding factor, and that is the husband is a high myope. So anyways, they've been told about these things, and sometimes even though the phenotype is very typical, one might land up with confounding results. Before I go on to this, I would like to mention about what is it that this ABCA4, what are my applications of it, common sense applications. Basically, this ABCA4 gene and the proteins it's responsible for, they are involved in the vitamin A metabolism in the retina and in the RPE. So these patients who have this mutation, basically, these are the cases where we must avoid beta carotene, okay? because if we load them with beta carotene, actually we are going to cause a toxicity because it can't be metabolized properly. Similarly, I check for two other genes. One is APOE and the other is ELOVL4. These are involved in long chain fatty acid metabolism. So often in all these inherited retinal disorders, most of us ophthalmologists are sometimes guilty of the crime of prescribing a Ramban treatment. We just give them, load them with vitamin A or other antioxidants and omega-3. So we need to be careful. If we load these people with APOE and ELOVL4 mutations, if we give them omega-3, actually we are helping to push them further downhill. So we should be aware and should not be committing that mistake. So this lady, she's very highly politically into a political family and whatnot. She presented with Stargardt's, but the gene workup threw up some very surprising results. There was consanguinity. The parents also showed the same thing. Parents were carriers. They did not manifest. The child manifested, but it's not RP that has manifested. So like ABCA4 is present in so many different phenotypic manifestations, I guess even some of the genes which are responsible for RP would be present in some of these other non-RP macular dystrophies. This is an 82-year-old gentleman with age-related macular degeneration with atrophy as well as high-risk drusen. So he underwent gene testing and he was advised that don't use beta carotene, don't use omega-3 also. But here the report mentioned it was based on the ARMS2 and the CFH. But to me, what was more important was the ABCA1 is highly risky and the APOE is highly risky. So that is the logic to me why we should not be giving him omega-3 and beta carotene or the carotenoids. Now, this was a patient with choroideremia. I advised him again gene testing. He refused. But then one could deduce because two younger brothers have nyctalopia, younger sisters don't have any manifested disease. I've not been able to examine them, but it's obviously X-linked recessive. May I please take another minute or so? Thank you. This was a lady with recurrent VKH syndrome. So on one of the attacks a few years ago, I started her on steroids and azathioprine to minimize the amount of steroids. And she went into severe bone marrow suppression. It was just very fortunate. She's a widow living in a different city in close to Mumbai. And living by herself at that time. It was just fortuitous that somebody from the clinic happened to phone her to just inquire. And we discovered that she was down with high-grade fever and whatnot. So immediately we told her to stop the azathioprine, contact the physician, and her life was saved. But on doing the WBC count, there was a severe suppression of all WBCs, RBCs, and platelets. So I referred her to the hematologist who asked for these tests to be done. The ACT on methotrexate, RFC1, MTHFR, and the TPMT. Now, interestingly, actually, what she should have had with that bone marrow suppression is a mutation of the TPMT, because it was azathioprine which caused, but that was reported as normal. The other two were reported as having abnormalities. I mean, so genetics can sometimes be really very confounding. Notwithstanding, on any patient, before I start immunosuppressants, I do get these 3 tests done. This is my last case, Wolfram syndrome. Classically, these young type 1 diabetics, they go blind, they have hearing loss, they have kidney failure, and they often die at a young age. Now, this is one such child who's, who's got optic atrophy, as you can see. We got gene testing done. The gene testing confirmed that yes, it is indeed Wolfram, but he also had diabetic retinopathy. I had to do extensive laser for him, proliferative as well as DME. Both manifestations were there, and the child is still surviving beyond the normal projected age. And I have a couple of other kids like this also. So what does this mean? Logically, it means that there is some Indian variant or some other Indian gene which is protecting these kids, which might be causing PDR and DME in these kids, but it's also keeping them alive. So what is the future according to what I can imagine? In the near future, we'll have gene tests for glaucoma, diabetes, myopia, so that we can predict that who's likely to develop this and who's not likely to develop, whose children are going to get these issues, who won't, and so on. But eventually, it's going to be EPP medicine, extremely personalized and precision medicine. So the patients, even before they come, instead of Aadhaar, the government of India is going to have genetic kundlis of everyone. That's going to predict what diseases they are predisposed to, what are the medicines which will be effective and procedures effective, what won't be effective, what medicine in what dose will be effective, and how can we prevent it. So thank you very much.
Thank you, Dr. Kamdar, for that peek into the future. We have only 15 minutes to wind up 5 talks and a panel discussion. So I invite the next speaker, Dr. Nikhil Nashta, for his talk on children with Down syndrome. No. Ocular albumin, sorry.
Next session.
Yeah, so we were just presented with another 30 minutes.
I won't take too much time, Siddharth. Thank you so much. It's my honor and privilege to be speaking at the first international GEGC, that too in Mumbai. And heartiest congratulations to Natarajan sir, and thank you Garobi ma'am for including me in the program. I am going to be speaking on ocular albinism. Let's give them a fair chance to see better. Albinism, we know that life isn't fair and all genetic diseases are a play of cards, a matter of chance. Anybody could have any genetic googly thrown at them. I've seen genetic diseases very closely in my family. Coming from a Sindhi small subsect, we have a lot of consanguinity and inbreeding and all. And my last slide, I'm going to show you what all genetic diseases we have at home. But yeah, unlike other genetic disorders, albinism, ocular cutaneous albinism does not place any limits on intelligence, fertility, or lifespan. So it's not a very bad genetic disorder to have. The world's biggest albino family, in fact, I'm going to go ahead. The world's biggest albino family, in fact, is an Indian family in which there are almost 7 albinos. So when we understand albinism, we talk about pigment melanin. So melanin is going through 3 steps where it goes from tyrosine to DOPA to dopaquinone to melanin. And tyrosinase enzyme is a major startup for the entire cycle. So in albinism, there are no pigment cells. It's an autosomal recessive disorder. Could be homozygous or heterozygous. It's mostly due to a missense or a nonsense mutation, which she explained very well to us earlier, like a library and a book with chapters and spellings which are going wrong. So this affects vision, and it's very, very common. Actually, all of us would have seen albinism. So it's to the ratio of 1 to 18,000. And it occurs in all the races. It's not specific to Indians or Africans or Asians. It's all over the world. only the variants vary in that. Melanin is of two types and it's important for vision. No melanin means a lot of light scatter in the retina. If you look at the genetics of albinism, there's OCA 1, 2, 3, 4, 5, 6, 7, and so many more. We'll concentrate on the first four. OCA 1 is lack of tyrosinase enzyme. It's again autosomal recessive, and here the first step goes wrong. So there's no DOPA, no dopamine, no melanin, no melanocyte. There's absolutely no pigment, neither in the eyes, nor in the hair, nor in the skin. So these are absolutely white with white hair, and they have no pigment in the iris. They have all the features in them. When you look at OCA2, it's a different gene altogether. In OCA2, we have a mutation in the P gene, and these people may have some color to the hair, they may have different colored eyes, but they definitely will have nystagmus and they will have photosensitivity and other things. They may have partial pigmentation, so they could have freckles on the face. When you look at OCA3, this happens in dark-skinned people, mostly East Africans. And here they have reddish brown skin. This is also called as rufous albinism because they look like the hair is like ginger or red colored. It's not so common in India, but we do see a few of them. And when we were kids, we used to tease them and call them orange delight. Because एक candy आता था कोई orange delight. We were mean kids. So yeah, ocular albinism, it's a different variant again. In this, pigmentation will be okay, but they'll have extremely white eyes. So it's like a Ramsay movie come to life. And they have a mutated X chromosome exclusively occurring in males. And here is where all the ocular things will happen. So albinism goes through a gamut of different presentations, OCA 1, 2, 3, and 4, or just an ocular albinism. They may have associated syndromes like a Chidak-Higashi or a Hermann-Pudlik, in which they have some disorders with phagocytosis, so they'll end up with staph and strepto infections, especially oral, or they have some sort of other syndromic variations. These are quite rare, but they do occur. There's in Hermann-Pudlik, we have a lot of platelet disorders, so we have petechial hemorrhages, and in the Griscelli, it's all gray hair. Albinism is different from vitiligo because vitiligo is later on in life where it's an autoimmune response towards your own pigment cells. It's patchy, and then it becomes overall in the entire body. So that's entirely different. Now, what are the symptoms of albinism? Essentially, they can't focus, so they can't see. Legally, these people are blind in places like US. They cannot drive or anything, but not such a thing in India. In India, we allow them to do everything. They will have macular hypoplasia. They'll have no pigment in the iris, no pigment in the retina, too much light going into the eye, not able to fix. And their optic pathways are also not very correctly aligned. So that crossing which should happen doesn't happen. And there's a mismatch in the optic pathway beyond the optic tract, chiasma and all. So they have nystagmus, crossed eyes, involuntary rapid eye movements, and impaired vision, even leading up to blindness in some cases. We diagnose them on the clinical appearance. When they walk in, you know what this is. There's no rocket science to diagnosing this. We can recommend doing an ERG for proving the diagnosis, but we really don't do anything. We know when they walk in what it is. We try to refract them to the best and give them a good acceptance. If they have too much of a nystagmus, maybe do some surgery to bring them to a neutral point where, you know, it's tolerable for them. Some genetic testing can be advised, but usually their concerns are more with intolerance to light and adapting to school. So just a pair of glasses, a visor, a hat, staying indoors, not going in the sun too much, using the correct glasses, maybe contact lenses, aniridia lenses, and so on is enough for them. This is how they present, and we can see across the various presentations, there's iris transillumination, there's a lot of no pigment in the retina at all, and all of that. This is also showing us that the reports are essentially normal. Other than lack of pigment, they don't have anything else really to be treated. Genetic diagnosis can be considered, but you're not achieving anything much unless these people want to go in for another kid. Now, if you look at these genetic googlies, what are the questions they have for you? Can two albinos have a normal child? Yeah, they can. Because there's a 1 in 4 chance. So they could have, but there is a chance and there is a risk. So this is what their concern is. Second, can it be caused by inbreeding? Yes, definitely. Consanguinity and inbreeding will increase the chances for albinism. Can it skip generations? Again, yes, it can skip generations. There may be families where there is no albinism, and then one of the generations, there are multiple kids. What is the probability that next child will be albino? Again, there's a 50% chance if you go at the genetic. Just some question answer solving is more what these people are concerned with. Now, is there hope for them? Yes, there is hope for them. Gene therapy can be done, which could be a somatic or a germline. When you do a somatic gene therapy, you replace the segments and you hope that protein will develop, but it may or may not. And if you look at a germline therapy, then you've changed the entire thing and all the kids born later on will be normal. You can give them low vision aids, but they don't reach that point usually. This is my family. 3 of my cousins have albinism and they haven't stopped living their life at all. They are all very successful. They run schools and they have big businesses. In our family, we also have idiopathic scoliosis. We also have polycystic kidney disease. So everything masala we have, but nothing, we are not worried. We celebrate, we live life. There's nothing to be sad about. And I enjoy with my albino cousins as you see in this video. It's not playing, but anyway, that's what it is. Thank you.
Thank you, Nikhil. That was a really nice presentation. I think so. The next talk we have is from Dr. Biswas. Dr. Biswas is an ophthalmologist who has specialized in uveitis and ophthalmic pathology.
Dr. Biswas is not talking. Hello.
Has a fellowship in VR surgery in Shankara Nethralaya, and he has published more than 445 articles today in peer-reviewed journals. He's a member of the International Uveitis Study Group, American Uveitis Society, and an executive council member of International Ocular Inflammation Society. He's the founding member and past president of Uveitis Society of India. Oh, okay. All right. So in place of Dr. Biswas, Dr. Krishna Kumar, who is a pathologist, in his place is, and his team is presenting.
No, it is not the
And
team,
he's
doctor.
talking on primary VR lymphomas and MYD mutation, 88L265 mutation.
Am I audible? Hello. Hello, am I audible?
Yes, sir.
See, I am a pathologist, and you cannot read somebody's CV, man. Okay, I am Dr. Krishna Kumar and my oncology colleague, Dr. Suganeshwari. I thanks Dr. Lahiri for the late invitation at night. And vitreoretinal lymphoma is a rare malignancy, and it is something like a central nervous system lymphoma, and it belongs to the ABC subtype of diffuse large cell lymphoma. 60% of vitreoretinal lymphomas are bilateral, and it mimics posterior uveitis. Diagnosis is challenging when there is no CNS lymphoma, and it is more challenging when the patients are already referred to a tertiary care center when they are on steroids or immunosuppressant drugs, or when they are taking treatment for tuberculosis.
Can you please share your PPT, please?
Or you're not able to see, sir?
We can see your Gmail, but we are not able to see your PPT.
Okay, sir, I'll just see. Are you able to see now?
Yes. Yes. Yeah.
Myself and my colleague, Dr. Suganeshwari Ganesan, is an oncologist at Shankara Nethralaya. I am the HOD of the pathology department at Shankara Nethralaya, trained at Doheny Institute. I think they read the wrong CV. I am a bit disturbed because of that. Vitreoretinal lymphoma is part of central nervous system lymphoma, and it belongs to the diffuse large cell lymphoma type. And 60 to 80% of vitreoretinal lymphoma, if they don't have a CNS lymphoma, then it is very difficult to make a diagnosis. It presents as uveitis, and it is more challenging because patients are already on steroids or immunosuppressive therapy when they are referred to a tertiary care center. This is the working algorithm. Usually what they do for a vitreoretinal lymphoma, they start with the biopsy. They do multiple techniques like immunocytochemistry, cytokine estimation, flow cytometry, molecular testing. But when it comes to the practical aspect, we cannot do all the testing because the sample is less. So we as pathologists must talk to the ocular oncologist and plan the test effectively so that we can give a correct diagnosis. This is our paper at IJO. in 2020, where Dr. Natarajan is also part of the team, where we had a large series of intraocular lymphoma, and we showed that MID88L265P mutation is there around 70 to 80% of the Indian population. We thank Dr. Sarah Copeland for encouraging to do this sort of study in the Indian population. However, post MID88 optimizing at Shankar Nethralaya, we had many challenges. I thought I'll share a couple of scenarios. There are medical legal issues in management of intraocular lymphoma. That immunohistochemistry is mandatory in centers in South India at some of the tertiary care centers where they don't accept MID88 L265P mutation, and the conventional oncologists still want immunohistochemistry information. However, I understand in North India and Delhi, other places, they want molecular testing, they want NGS data to start the treatment for lymphomas. However, the experience in managing intraocular lymphoma is not that much. In scenario 1, it is a classical case where everybody is happy. You get a classical fundus photography of a lymphoma. This cytology, you find necrotic cells, large atypical cells. The pathologist is very happy, and we do cytochemistry. CD20 is positive, and we do the PCR sequencing mutation for MID88. Yes, you see this mutation, heterozygous mutation. This is a control showing non-lymphoma, CMV virus. So when we see like this and it tell cytochemistry is positive, heterozygous mutation for MID88 is positive by PCR sequencing, everybody is happy, and the case therefore goes to the oncologist. When the case goes to the oncologist, when there is a PET scan or MRI taken, when there is a lymphoma elsewhere in the brain or elsewhere in the body, he's happy to manage the case. However, if the MRI PET scan does not show lymphoma in the brain or no other systemic lymphoma, it is very difficult to convince the oncologist at general hospital to manage the case. It is only an understanding and dialogue. That what I understand from Dr. Suguneshwari, who manages this. She talks to the Apollo oncologist, she talks to the other cancer oncologist, and they plan the management when the patient does not have lymphoma elsewhere other than the vitreoretinal involvement. Second is a non-classical case. We had a case when the patient is a doctor from Delhi, the daughter is a pathologist from Delhi, and they had the vitreous biopsy done at Delhi, and nobody were willing to give a report, and so she was referred to Shankar Nethralaya. And this is the summary made by Dr. Suguneshwari. Vitrectomy done, blurring of vision in both eyes. He had treatment for tuberculosis, and this is the scan image of multiple hyperintense lesions in brain. With this, the slide came to us. This is the vitritis information. And we saw a lot of necrotic cells, atypical large cells. So they were insistent that we need to do molecular testing NGS. So I gave a report as atypical large lymphoid cells in a necrotic background. This is suggestive of large cell lymphoma. We will do molecular testing with NGS panel as it was needed by the Delhi oncologist. So then what we did, we started with MID88. Surprisingly, MID88 was negative in that particular case. We know that MID88 mutation L265P is positive only in around 75 to 80% of cases. So we were stuck. We said, yes, we have the DNA. So we will send the whole DNA to MedGenome for clinical exome sequencing. That was the discussion we had with the doctors. So, but once we sent the sample, they want 300 nanogram of purity, and they said the turnover time is 4 weeks or more for giving the report. And the charges were approximately 40,000 rupees. And if the QC does not clear, they'll return the money back. That's what they said. And so we were reluctant, but what to do? We sent the sample to MedGenome because we needed a diagnosis. Then after a couple of days, they said the DNA sample QC report failed. So they said we cannot take this sample for exome sequencing. That was the report from MedGenome. We were stuck one. The doctor was the patient and his daughter was very much stressful. There is no diagnosis. We know there is vitritis. So fortunately, when Dr. Suguneshwari did the vitreous biopsy, she had given us diluted and undiluted sample. So diluted sample we did not discard, and we had made a cell block. And so what we did, we did sections and we sent it for immunohistochemistry panel to a commercial lab, which does the went on auto stainer. And we were happy to see that we are able to get all the cells are CD20 positive. You can see clumps and clumps of cells are CD20 positive, CD3 completely negative, and Ki67 was on the higher side. So this was very, very good. And we said this is immunohistochemistry is positive. So most likely this is large B-cell lymphoma. This information, the image, everything was sent to the Delhi doctor, to her, and the Shivganeshwari spoke to the patient and to the oncologist there that this is systemic lymphoma, that this is vitreoretinal lymphoma. So they start on CHOP protocol. I understand. A few weeks back, the patient got a systemic chemotherapy started, and they are very, very happy. How challenging it is. That's what I want to tell scenario 1 and scenario 2. Now, the why we had problem in the scenario 2 was MOD88 mutation is only positive in say around 74% of cases. There are other mutations like PIMI, CD79B, and IGLL5. So many other mutations are there that the Thermo Fisher has got their large cell lymphoma panel genes, which they recommend for general large cell lymphoma, and concurrently for intraocular lymphoma, these panels are now recommended by NGS because we may pick up mutations other than the MID88. And also in MID88, we only do L265P. There is also 243N, where around mutations can happen. And by knowing the presence of these mutations, there are some target therapy by brutal kinase inhibitors. By knowing that CDK and 2A loss, we can put on some inhibitors. CD7 mutation tells us there is early development of CNS lymphoma and methotrexate resistance. So NGS is recommended, but the drawback is NGS when the patients are already on steroids or somebody, they have vitrectomy done elsewhere, and when they come to tertiary care, we don't get the sample or adequate DNA for NGS testing. So what are the lessons learned from this case? NGS clinical exome panel, the turnaround time is 4 weeks in India. And the QC failure is high from vitreous as the cells are free and the patient has already gone steroid therapy. We need to have a trained oncologist. So currently, now I don't encourage any general surgeon or vitreous surgeon doing vitreous aspirate and sending it to me. It must be an oncologist, or they must have a dialogue with me and my colleague, Dr. Suguneshwari, who is experienced in giving me the clinical information. And MID8 L265P is negative in 30% of cases. In those cases, we must be ready that there could be mutations in other area, and talk to the oncologist. And we must have a plan B that whether we can have the vitreous aspirate made into a cell block for immunohistochemistry. And the cost for NGS for a clinical exome sequencing for lymphoma is around 40,000 rupees, that's for by Medgeno. And thanks a lot. I am willing to take any questions or any doubts. I once again thank Dr. Lahiri for giving me the opportunity, and also a bit disturbed that they told my CV wrong. I am trained by Professor Nasing Rao at Day-1 Institute. I am at Shankar Nethralaya for the past 22 years. I have 250 publications, and I work along with Dr. Jyotirma Biswas.
Sorry, sir. Actually, I would like to apologize on behalf of the organizers for not introducing you. You are the head of Department of Pathology at Shankar Nethralaya with last 25 years of experience. And you have mentored 15 students for PhD. And you have got training in pathology from USA. And thanks a lot for a nice
Thank you,
talk.
sir. Thank you, sir.
And once again, sorry for the...
It's okay, sir.
Yeah, thank you. So our next speaker is Dr. Ajay Dudhani.
It's my pleasure to introduce Dr. Ajay Dudhani. He's a prominent vitreoretinal surgeon practicing in Mumbai for the last several years. And he's a Shankar Nethralaya alumni. And welcome to you. And he will be speaking on a bouquet of wheel Marchesani syndrome cases.
Where are the other ones?
Yeah, thank you so much. I'll be very brief, I'll be talking to you about Whale Marchesani syndrome. I had a series of 4 sisters who had this syndrome,
So I'll be very brief. So it's also called as spherophakia brachymorphia syndrome or mesodermal dysmorphodystrophy syndrome. So this is how the children came to me. You know, they were not, they were young girls, like the eldest sister who came to me when she was 16 years old. She came with the IOL, the clear lens with a microspherophakia in the anterior chamber, and she came with an attack of acute congestive glaucoma. So that's how the story started, and this girl had to undergo an emergency lensectomy through the limbal region, and we had to put in an AC IOL in her case. And we treated a myopia also and her glaucoma in this case, and the other eye we did a similar surgery to prevent this occurrence. So what is the basic genetics of this disease? It can present as a sporadic mutation, or it can be autosomal dominant and recessive. The genes associated with this syndrome provide instruction to the production of enzymes and the extracellular matrix proteins responsible for connective tissue integrity. That is why we have the problem with the zonules in these patients in the eye, which we have. And the gene described is the FBN1, and the autosomal recessive Weil-Marchesani syndrome. There are various genes which are there, which is listed here and accounts for 45% of the cases. The sporadic mutations accounts for the remaining 10% of the cases. So you have autosomal dominant, recessive, and they almost divided 40% each. So this is a rare disease. It's 1 in 1 lakh, and I had a family which I saw, and I was quite, shocked to see how it can be, very debilitating for these people. So the problem which my patient had was secondary glaucoma, which they came with, either due to the narrow angle or the lens coming into the anterior chamber. They all were having little brachydactyly, and none of them had cardiovascular defects because we operated all of them under local anesthesia after getting fitness. And they all had ectopia lentis, and they were little dysmorphic. They were all short in stature, the patients which I had, and they can have joint limitations, but my patients didn't have that. So the other ocular abnormalities are usually recognized in these children during routine eye examination, but these patients came to me after the first sister had this problem of acute congestive attacks. And they have a microspherophakia. The lens is spherical and small, and the myopia is secondary to this spherical nature of the lens. It is not an actual myopia. And the secondary glaucoma is due to the iris lens diaphragm getting pushed anteriorly and causing a narrow angle glaucoma in these eyes. And they have an increased corneal thickness, and the high myopia is very common in these patients, But there is no presence of any retinal changes like in high myopia, you get lattice degeneration or white without pressure. They all had short stature in my patients and brachydactyly. Thick skin is common. Cardiovascular defects can be seen like PDA and pulmonary stenosis. So this is how you get, typically you have this lens which is there. You can dilate and see the zonules so clearly. It looks like it's a very dramatic photograph you take in these patients. And the magnifying picture, as you can see here, you have a narrow angle, and you can have glaucoma flecken, and gonioscopy shows a very narrow angle. So you can actually, try sort of a PI in these patients, but I've seen that in none of my 4 patients, the PI worked, And because the whole lens is pushing the iris lens diaphragm, so it doesn't work very well, And on UVM, you can see that the narrowing of the angle is there. So the zonules, as you can see, there is pigmentation, and there are long zonules which are attached, improperly. They don't come fully anteriorly. And there's a defect in the fibrillin gene. The glycoprotein is impaired due to the genetic change. And fibrillin is the main component of the ciliary zonules and the blood vessels, lungs, ligaments. That's why the problem in the heart and the zonules here we have. The mobility of the lens leads to the refractive shift of myopia. So basically, you can pick this up clinically very easily, and there is genetic testing which is done here to find out the gene changes. These are the various differential diagnoses which you can get. So management, basically, there's no cure, annual examinations, avoid dilating or constricting the pupil in these patients. And glaucoma should be looked out for that. And because they have an increased corneal thickness, you might, end up over measuring the IOP also in these patients. So annual examination is very important. So this was the 4 sisters I had. So this is how we did, I just want to show this video for you also that can make a little from this drab talk. So we did a pars plana, or we did a limbal lensectomy in these patients, constricted the pupil, and in all of them I ended up putting an AC IOL. And the beauty was that because they were girls, the parents were extremely happy that the high myopia, which was almost like 12 diopters, was also cured by this surgery, along with treating the glaucoma also in these patients. And the results were extremely gratifying. And they had a history of consanguineous marriage in the parents of these children. And they all presented with high myopia and narrow angle glaucoma. Post-surgery also, I maintained the patients on anti-glaucoma medications in these patients. So the eldest sister presented with an acute congestive attack, and this is how it looked, post-op, all these girls. This is one of the children ka photographs which we had. And she required urgent surgery. We did it immediately the next day after controlling her IOP with medical management. And she was emetrope, and we did the other eye, same procedure as the interval lensectomy and anterior chamber intraocular lens implantation. And she has been maintaining a vision of 6/6, and we're just giving a prophylactic single glaucoma drops in this patient. The second sister came with an acute congestive attack. This was not due to the lens being subluxated in the AC. It was in the posterior chamber, but it had pushed anteriorly. And she also had to undergo a urgent limbal lensectomy. So this lensectomy I do with a 20 gauge past planner opening with a AC maintainer. And usually because they're young, so the hyaloid is quite well developed. So you not necessarily need to do a vitrectomy in these patients. And you could also use the iris clip in these lens. In one of the children, I tried to do a sort of a ECC and maintain the posterior capsule. And I thought that I might be able to put a PC lens, but the zonules are just present peripherally and you can't support the lens, on the central capsule, because the periphery just has the zonules and the whole lens is microspherophakic and small. So you can't put a PCIOL in these patients, though I managed to do an ECC in these patients, and maintain the rexes and the posterior capsule. The lens back doesn't expand only because the lens is small in size itself. So this is how the picture looked of one of the sisters whom I did, the third sister in the family, which we did. So after the first two elder sisters had this acute congestive attack, the other two sisters came for an interval lensectomy and intraocular lens implantation. And they were extremely happy because through serendipity, we could also treat their high myopia, which was the very main bugbear in this population, that the girls are having such high glasses. So the take home is, if you diagnose in time and the treatment is very effective, it's usually surgical in most of these patients, and you can prevent glaucoma and also treat myopia. Thank you very much for your patient hearing.
Thank you, Dr. Ajay, for a lovely presentation. We are going to invite our next speaker, Dr. Himika Gupta. Dr. Himika is an ocular oncologist and an ophthalmic plastic surgeon with special interest in artificial eyes and eye care for cancer patients. She is trained in ocular oncology from LV Prasad Eye Institute, Hyderabad, and after that trained in Canada. She's a consultant ocular oncologist at Narayana Hospital, Bangalore, and she currently runs her own clinic in Navi Mumbai, is also attached at Tata Memorial Hospital, and she's ophthalmology in charge at the NGO Doctors for You, which caters to disaster-stricken regions and Mumbai urban slums. Welcome, Himika.
Thank you, ma'am. Thank you very much, ma'am. I thank the organizers and Dr. Kerovi, ma'am, and Dr. Natarajan, sir, for giving us this opportunity, and really congratulate the Indian ophthalmologists for having a dedicated genetics conference. Respected seniors on the dais, I would like to acknowledge my past affiliations, and today I'll be talking about retinoblastoma genetics. So retinoblastoma, as we all know, is the commonest primary eye tumor, and it arises from the immature retinal cells. Any residents in the audience? Raise your hands. One only? Two? Okay, fine. Fine. So we should know who our audience are. Although it's a very rare tumor, it's just 2% of all pediatric malignancies, but the retinoblastoma gene makes a lot of waves. We've already read about it a lot. If we were to look at the classification, it is classified, the intraocular disease is classified from A to E, where a smaller tumor is easier to treat and the vision is not affected, and a larger tumor might need enucleation or eye removal. So why is genetics of RB important, and why as clinicians we need to pay attention to it? Okay, so as many of you might know, not so long ago in 2020, in the 8th AJCC, age or heredity was added for the first and only tumor, which is retinoblastoma. So apart from the TNM, we have now H0, H1, and HX for retinoblastoma. So we know that hereditary is important. So 60% of RB cases are non-hereditary, which could be sporadic, and around 40% or 1 in 3, 1/3 could be hereditary. It is an autosomal dominant gene. So first thing to remember, no role of consanguinity. Second thing to remember, it is not confined to any ethnic or religious group, and it has, again, nothing to do with consanguinity. However, there are sporadic reports where they say that perhaps increased paternal age may contribute to retinoblastoma. It is a huge gene. So long and short is, to analyze the RB gene and deduce answers can be a bit tricky. It may not be black and white. Early detection is the key to success in RB treatment. So let us see that those of us who deal clinically with patients and with retinoblastoma, how genetics can come to our rescue. We all know this guy called Knudsen. In 1970s, he gave the famous hypothesis of first hit and second hit. In the interest of time, I won't go into the details. But basically what his paper said is that most of the unilateral cases did not have any genetic basis, which made us believe that unilateral retinoblastomas are non-hereditary, and that's how we commonly practice or counsel our patients. This is one of the case examples when I was working in Bangalore, Narayana, of a unilateral RB, which turned out to have a mutation. So he had partial response to the first line of chemotherapy, although it was a salvageable eye. He developed subretinal seeds. Secondary, finally, we could not really salvage the eye and we had to enucleate. So the next time when we see a unilateral case, we have to remember that this could be a hereditary retinoblastoma. So this patient is a current day case at Bombay, and when this unilateral group D retinoblastoma, who has responded to therapy, thankfully, when her parents came to us asking that can we plan another child, we remember to get the child genetically analyzed, because we don't want the family to have the same case scenario again. So the take-home message from this example is that do not assume unilateral retinoblastomas are non-genetics, and that's how we should counsel. So I would like to say what our oncologist at SRCC often says, that genetic testing is more relevant in unilateral. But does that mean that it is less relevant in bilateral? Well, let us look at the next example. My colleague Shruti already spoke about this case, who came to us as a bilaterally blind child with advanced disease in both eyes. And we had no other choice but to do bilateral sequential enucleation. The child underwent complete therapy, and she had coping up issues, the mom would say. And we always assumed that this was because she was blind since birth, and she had undergone so much of chemo and so much of other trauma, and of course, bilateral surgeries. When we send the child for genetic testing initially, and Shruti very nicely has explained everything, I really thank her for that. The testing came negative for the gene. That's when the geneticist was involved, and they had a look at it, and they said they decided to do a microarray analysis, because that single gene was not picked up. And that's when they picked up a large deletion of the long arm of chromosome 13, which means that a very large piece of chromosome 13 was missing, not just the RB gene having a mutation. So this was a case of syndromic RB, where there was an associated facial dysmorphic features, delayed speech, and delayed milestones. So in these kind of bilateral cases, when you have retinoblastoma with a developmental delay, actually the genetics forms the backbone of the diagnosis, and the multidisciplinary team comes to our rescue. So this is how she is now well rehabilitated. Of course, it has to be a teamwork. So the challenges that we also need to think about are that RB is a big gene. There can be many alterations, and technically to pick up everything may be a bit tough. Sometimes in bilateral disease, there could be false negative, wherein we have to look at other things like mosaics or some very deep intronic mutations. This was a very nice paper that I had a opportunity to work on, and it got published last year, where we looked at the case-based genotype-phenotype analysis. And this was the work done in Bangalore. And of course, with MedGenome, the entire team who was involved, many of them are here in the audience and speakers. And what we realized is that first, there could be unilateral retinoblastomas who are gene positive or who have mutations. So you have to follow them up as a hereditary RB case. Associations of disease recurrence and progression were higher in gene positive cases. This is how the entire RB, the mutations looked. So risk of recurrence and treatment failure in retinoblastoma increases with positive genetics, and unilateral cases also could be positive for RB gene and mutation. And if we don't pick it up from our genetic testing, then we may miss out. So we may tell these patients that, okay, go ahead, you can plan a family. The next person in your family will not get retinoblastoma, whereas they are gene positive and they might get retinoblastoma, just like the hereditary bilateral cases. Other things that you can offer to such patients would be prenatal molecular testing, like amniocentesis once the person at risk is pregnant, or pre-implantation genetic analysis, where they have a choice through in vitro fertilization to decide which embryos should continue and which should not. And third is postnatal genetic testing. Once the child is born, do the genetic testing, look for the RB gene because it's a familial situation, and do aggressive screening and watch out for new RB tumors. Also, all these patients have risk of second malignancies. The last is the hurdle for mutational screening. And as we all know that the costs are reducing. This was a survey done in Bangalore, and the current cost at that time, and I'm talking of 2016, was around 25% to 25,000 to 60,000, whereas patients want, like that is their expectations, 2,000 to 10,000. So there's always that gap, which maybe the clinician will have to learn to bridge based on having a self-awareness that this genetics will help them treat the disease better. And obviously that should translate into how we counsel or approach the case. To conclude, reasons for genetic screening in retinoblastoma: it indirectly reduces the cost of care. Like you need not screen siblings, you need not call them for very frequent examination under anesthesias. The prenatal diagnosis and for counseling for family planning. You may want to avoid radiation in germline or cases which are proven hereditary. You will be able to pick up the unilateral hereditary, which otherwise get missed as unilateral sporadic back into the population, and customize your surveillance protocols to pick up second malignancies in these cases earlier. This is from this year's retinoblastoma survivor event. I am very fortunate to have a very good team at SRCC, and also that we are able to include genetic testing as a part of our clinical management for retinoblastoma, not just for research. Thank you very much for a patient listening.
Thank you, Dr. Himika. That was a very nice talk. To give the concluding talk, I'm inviting Dr. Mayur Morekar. He'll be speaking on LHON. Dr. Mayur Morekar is a very well-known uvea specialist. He practices from Bombay Hospital, and he has a list of best poster and best paper awards in India and abroad.
So while he's setting up the talk here, I was talking about this. I'm feeling blessed to be presenting from this podium here. Today is Dr. B.K. Goel's birth anniversary, and he has been one of the pioneers of Bombay Hospital Institute of Medical Sciences. And I work here as an associate professor. That's thanks to him. So I start all my presentations with acknowledgements to my teachers. And this talk is about Leber's hereditary optic neuropathy. And I would like to thank the co-authors, Dr. Satish Khadilkar and Dr. Singhal, and one of our ex-residents, Dr. Tanuj Sharma, who's now in New Delhi. These are the points for the presentation. To introduce the topic, Leber's hereditary optic neuropathy is one of the most frequent mitochondrial diseases. It was first described in 1871, but it had been noted earlier than that in 1858. The first point mutation was discovered almost a century later in 1988, and it was in the MTND4. And I want you to just keep that MTND4 in mind. The other 2 point mutations which were later described were in MTND1 and MTND6. These 3 mitochondrial DNA mutations are responsible for approximately 90% of the LHON cases. Coming to the second part, now in order to avoid blocking the light to reach the retinal pigment epithelium in the macular region, and particularly in the papillomacular bundle, the retinal ganglion cells are unmyelinated and have narrower caliber axons. Now, because this anatomical peculiarity is associated with an increased energy requirement when saltatory conduction is of the action potentials is absent in this part, and therefore the macular ganglion cells demonstrate to have mitochondrial clustering and are specifically sensitive to energy depletion and reactive oxidative species accumulation, which happens in these mitochondrial dysfunctions. Now, all the mutations disrupt subunits of the mitochondrial complex 1. So there are 3 complexes, 1, 2, 3. All the mutations disrupt the complex 1, impairing electron transfer and the ATP synthesis. This is another thing that needs to be kept in mind. Now, coming to the case report, this is the patient who got me interested in this disease. He presented to us way back in October 2014. His first presentation was elsewhere, from where he was referred to us, a gentleman. Sudden painless loss of vision, left eye more than right eye of 6 days duration. A best corrected visual acuity at initial presentation elsewhere was 20/20. Left eye, it was finger counting 3 meter. Both eyes fundus examination was documented to have disc edema, more in the left eye. This patient had pulmonary tuberculosis since February 2014. He had been on 4-drug AKT, of which pyrazinamide had been stopped at 4 months. So at presentation, you see that's about 8 months of ethambutol going on. The left eye decrease of vision was first noted on the 1st of October. So that's almost 8 months since beginning of AKT. AKT was stopped at his presentation elsewhere, which was on the 6th of October. Now, despite stopping the AKT, the patient progressed to have a decrease of vision in the left eye. We had the visual evoked potentials with us, which were done elsewhere. The right was normal, the left were affected, and MRI brain was normal. He had received 5 doses of intravenous methylprednisolone, and there was no improvement in vision. So here we note that there has been a painless. Now the word sequential is important. It was the left eye which had presented, and then the right eye. In October 2014, you can see the fundus picture. Right eye, the best corrected visual acuity was finger counting 2 feet. Left eye, it was finger counting close to face. And one can look there, there is a disc hyperemia and peripapillary tortuous vessels. It's more obvious in the red free photo. This is of the right eye and this is of the left eye. Now, this clinical picture of a disc hyperemia in a young patient with a painless sequential bilateral loss of vision made us think of Leber's hereditary optic neuropathy. And because he had been on AKT, and because we thought that basically it was ethambutol which was causing this, I read up a bit, and then the possibility of an ethambutol-induced manifestation of Leber's hereditary optic neuropathy was what we thought of. We had asked for the genetic testing, which he did 3 months later. And you can look at there, it is the ND4 which is detected. Now, the ND4 is the most common one which is detected, and it becomes important because the ND4 is the one which is the amenable to gene therapy. This patient was then put on idebenone. It was at that time we weren't really sure of the doses. We put him on 450 milligrams per day of idebenone and CoQ10 200 milligrams per day, although CoQ10 could have been dropped because it cannot cross the blood-brain barrier. So it is only idebenone which is important and which would have worked for him. The patient ultimately had an improvement in vision, binocularly became finger counting 3 meters N12 with plus 14 diopters. And he finished his first semester of computer engineering, this by 2015. Now, since then, 2015, the patient has been on follow-up. And we have almost a 7-year follow-up of this patient. The last follow-up was just 1 month back. And you can see how that disc hyperemia has now resolved. It's like a primary optic neuropathy. This case has been published. So coming across to this concept of conversion in LHON, these are the offending agents, and these agents could convert a patient with a genetic mutation of LHON into LHON. Now, what's important here to understand is that among the toxins, one of them is cyanide. So when these patients are treated with vitamin B12, one needs to be careful and not supplement them with cyanocobalamin. One needs to supplement them with methylcobalamin. Cyanocobalamin supplementation itself will precipitate an LHON. So what are the therapeutic options? The therapeutic options are very few. Quite a few of them have been tested. We will go to the lesser known ones first. This is EPI 743, which is vatiquinone. It is an antioxidant drug. And there is this another drug which is called elamipretide, which increases ATP synthesis and reduces the ROS production. But perhaps the most important molecule which has been proven to be working in this disease is idebenone. It has been approved in 2015. So if you understand, this is the approval for this drug is just around the time that we were treating that patient. It is a very strong antioxidant that restores ATP synthesis at a mitochondrial level in the LHON patient. It bypasses the complex 1. So there is direct electron transfer to complex 3 of the electron transport chain. And it is because of that it works. Now, the exact protocol in which idebenone is used in this disease has been established and published in 2021. The treatment should start within the first year of visual loss onset. So that's a huge window period that we have to think to begin this drug. The dose is 900 milligrams a day. It has to be continued for at least 12 months, and then it may be discontinued if the patient has reached a plateau or if there is no further improvement. Coming to the last part, that is gene therapy. I spoke about this. It is the ND4 which is amenable to gene therapy. Gene therapy involves having a wild type ND4 subunit that is packaged into adeno-associated virus and injected into the vitreous. There have been 2 double-masked randomized control trials which have proved the efficacy of this agent, not only in the injected eye, but also in the fellow eye. And that is because of a retrograde transchiasmatic transit of the vector from the treated eye to the sham eye. So the take-home message from this is, if there's a diagnosis of LHON, you'll have 2 things: the patient with the visual loss. If less than 1 year, then suppress the entire environmental factors. Like we did in our case, we stopped ethambutol. Give idebenone and consider gene therapy if the gene is amenable. If it is more than 1 year, obviously you go to visual rehabilitation. Families can be tested for the mutation. The patients require a lot of psychological support, genetic counseling, lifestyle counseling, and obviously the financial support is required. This patient of ours is now in the US. He's completed his engineering, and he has been in touch with me and is looking at these gene therapy trials that are happening there, and probably we'll have soon a word about it. Thank you.
Thank you, Mayur, for an excellent talk. And I think we'll go ahead with the panel discussion. Should invite the panelists. Okay.
I think we can have a couple of comments from each of the panelists. Nipa,
Nipa is right here, and Dr. Anaga is, Dr. Mamta is here.
And Dr. Mamta.
Dr. Natarajan, I don't know where sir is. Is Somil Seth here?
Yes, what Dr. Krishna Kumar was saying about the collection of sample and all those things. I think all vitreoretinal surgeons are capable of collecting the sample. First of all, there should be no discrimination. What is required is stop the steroids for at least a week in those suspected PVRL cases. And nowadays we all try to use the smallest possible cutter gauge. There you use a 23 gauge cutter, use it at a slow cutting speed and moderately high suction, instead of us trying to do our vitrectomies very fast, so that the cells are minimally distorted or destroyed, and then preserve it in I normally just take it in a syringe, keep it in between ice packs and just send it off. So I think
I request Dr. Preetam Samant to give memento to our speaker, Dr. Paritosh Kamdar, sir, Dr. Preeti Kamdar, Dr. Hemika Gupta. Preeti, yes.
my best half. Thank you very much.
Dr. Hemika Gupta. Dr. Mayur Morekar. Dr. Nipa Thakkar. Yeah.
Some gentlemen you want to give. Provided Dr. Kesavani husband talk and this time for the first time and last time, I don't know how many times I've heard the talk. Yes. Because it was a pleasure with all of you. This is a locality based. Referral bias. Referral bias, yes. Thank you very much. Thank you.
Give this to me. Others also repeating.
Oh, yes, yes. Now let go give all of me. You come and give Sonal. Sonal, please come. Yes. Yeah. Great.
Thank you very much.
I think that ends our session. A vote of thanks to Dr. Karobi and Dr. Natarajan for the wonderful conference and all the panelists and speakers.
Sir.
Slightly. Yeah, yeah. You want to come?